So I'm Lauren Puryear. Thanks so much for that nice introduction. And I'm going to talk today about understanding genetic testing. Peter and I did not coordinate our talks, so I'm going to touch on some of the same topics, but I think that's actually useful to get a couple of different ways of describing the same thing, because sometimes this feels very complicated and like it's really not even in English. I don't have any financial disclosures for this talk. And these are the three chunks of information that I'm going to try and touch on. I'm going to talk about a couple of genetics concepts just to make sure we're all on the same page about how DNA works. And then I'll talk about how to read a genetic test report and show you some examples. And then I'll talk about what you can do with that information once you have it and understand what your genetic test report is telling you. So think back to high school biology or forward, if there's anybody watching who has not taken high school biology yet. You may remember being introduced to this concept of the central dogma of biology. And this is just the idea that DNA is the instructions, and through this process, it leads to cells being able to make a specific protein that they need for something. So DNA lives in the cell nucleus in the center, and it does not leave the nucleus. It's sort of like a reference book at the library. It doesn't get loaned out. And so when the cell wants to use the instructions in that DNA to make a protein, they have to figure out how to get the information from the DNA out to the outer part of the cell where the ribosome, the protein factory, is located. And the way that that works is that the cell will transcribe the message or the instructions in the DNA into a little piece of messenger RNA. And that can travel out of the nucleus, and it can go find a ribosome, and it can get translated into a protein. The ribosome will read the instructions in that messenger RNA and assemble that protein one amino acid at a time in the proper order until it gets to that stop message in the messenger RNA, and then it knows that it's done with the protein and it's fully assembled. If I lost you at Central Dogma because it's Saturday and this is too sciencey, one other way that I like to think about this is that genes are like a Lego instruction book. And you may be able to tell that I have children, and I've got a lot of Lego instruction books in my house, and each one tells you how to make a specific end product. So block by block, you add on one piece at a time until you get the final product that you can use for something. If you have a genetic variant or a mutation in the instructions, that changes which bricks you're told to add to your final product. And so it changes the protein that you can build from those instructions. As Dr. Byers mentioned, sometimes you have a more dramatic difference in the instructions. And so you might end up with a protein that looks much more different, and that maybe the function would be impacted a lot more by some kinds of genetic variants than by others. And as Dr. Byers also mentioned, sometimes instead of having a swap of one building block for another, a genetic variant might tell the cell stop early in the instructions instead of at the end of that gene. And when that happens, the RNA, the little messenger RNA that's created, is very unstable. And so it actually doesn't end up making it all the way to the ribosome to build a partial protein. It gets degraded by the cell before that ever happens. And so when you have an early stop signal, typically no protein is made at all from that copy of the gene. The other concept that I wanted to touch on, which Dr. Byers also covered, but is very important to think about, is this idea of autosomal dominant inheritance. So in this diagram, you can see there's a couple, and one of them is shaded in to show that they're affected with the condition. And each of them has two copies of the gene that's involved in this condition. And the person who's affected has a little genetic variant there marked by the red X on one copy of the gene. Their other copy of the gene looks typical. It has the usual DNA sequence. So when this couple has children, they each get to pass on one copy or the other of that gene. And so for the children, they've got all these possible combinations. And about half the time the children will get the copy of the gene with that variant. And about half the time the children will get the other copy of the gene from their affected parent. Doesn't matter which copy the unaffected parent passes on because neither one of them causes this condition. And I also put a little note here to myself to make sure that I say that autosomal means not sex-linked. So it doesn't matter what sex or gender the parent is. If they are affected and they have one copy of the gene with a variant, they can pass that variant on to any child. It's a 50-50 chance each time with each pregnancy. Here's my little summary of autosomal dominant inheritance. And I will note that Marfan syndrome, Loeys-Dietz syndrome, and vascular EDS are all usually inherited in this autosomal dominant pattern. I'm not going to touch on other inheritance patterns. Dr. Byers already talked about some of those other things. But this is usually the kind of pattern that we're looking at for a lot of these hereditary aneurysm conditions. Okay. So I imagine this is the bulk of the talk for most folks, is how do you read that genetic test report and what do you do with that information? Because sometimes when you look at a genetic test report, as I mentioned, it doesn't even look like it's in a language that you understand. So here's an example taken from an actual genetic test report. If the laboratory finds a variant, they will list it out in a table or in some sort of highlighted fashion to say, this is a variant that we found that we think you should know about. The first thing that I look for is, what gene is this variant in? And that should not be hard to find. In this case, it's the FBN1 gene, which is the gene associated with Marfan syndrome. The next thing that I look for is, what is the specific variant in that gene? And it's described in a couple of different ways in most cases. So here you can see there's a C dot description of the variant and a P dot description of the variant. The C dot description is telling you in the coding DNA or the cDNA, at what position does this variant happen and what's the change? So at position 776, instead of the DNA building block that we call G, in this case, it's been switched to an A. So it's just a swap of one DNA base for another. And then if you look at the P dot description, that tells you what happens to the protein because of that change in the coding DNA. And in this case, it's also a substitution. So one amino acid is substituted for a different amino acid at position 259 in the protein. So this is a substitution variant. And sometimes that's also called a missense variant, where something's just swapped for another thing, but the rest of the protein stays the same. The next thing that I look for is how many copies of this variant were identified. And so that's listed here as zygosity. A heterozygous variant means one copy of that gene has this variant, and it's different from the other copy of the gene, which presumably has a typical DNA sequence. If there isn't anything else listed on the report, then we assume that the other copy of the gene looks typical. If somebody had two copies of the same exact variant, that would be called homozygous, but that's pretty unusual in these hereditary aneurysm conditions. Typically for an autosomal dominant condition, we're looking at a heterozygous variant, so just one copy. And then the last piece of information that I look at, and possibly the most important, is that variant classification. So in this case, this variant is called likely pathogenic. There's pretty good evidence that it's harmful, that it causes the condition that we're concerned about. Genetic test reports vary. They're all structured and formatted a little bit differently. So I'll give you one other example. This is a different variant, also in the FBN1 gene, but you can see all the same information is listed in this test report as well. So you see the gene there, you can see the DNA change and the protein change. This is a different substitution variant. It is also heterozygous, just like the first variant, and it's also classified as likely pathogenic. So these are two different positive genetic test results for people who have Marfan syndrome. As Dr. Byers talked about, there are 5 different categories of variant classification. This is all laid out by the American College of Medical Genetics and Genomics, and they have a structure or a system of what types of evidence you can use to classify things in these different categories. In theory, that means that different labs that look at the same variant should all classify it in the same way. But of course, in practice, all of these structures for interpreting variants are used by people, and people interpret things differently. But usually you can be, pretty close in interpretation between lab to lab in most situations. Laboratories do not report benign or likely benign variants in most cases because there are lots of them and they don't have any impact on people's health. And genetic test reports are plenty long enough without including that extra information. A lot of times, if you really want to know about benign or likely benign variants, you can ask the lab for a list, but we don't routinely do that. Typically, what we would see on the report is just if there's a pathogenic, likely pathogenic, or variant of uncertain significance identified. I do want to point out that variants of uncertain significance cause people a lot of headaches, as Dr. Byers mentioned. They're very common in genetics. We expect to see them on at least probably 10 or 15% of test reports, if not more, depending on how many genes we're looking at. There's just so much genetic variation between people that we don't understand well enough to know what it means. Most of that genetic variation is harmless. It's benign. And so we don't use variants of uncertain significance to make medical decisions in the vast majority of cases because we don't know what they mean. And we don't want to test other people in the family who don't have any clinical features of a condition for a variant of uncertain significance, because we wouldn't know whether to be concerned about them or not if they have the variant or if they don't. The majority of uncertain variants do eventually turn out to be benign or likely benign if we get more evidence and we can reclassify them. So we just leave them sitting on that test report, sitting in the lab databases, and the labs are constantly trying to gather more information. And as Dr. Byers said, if you have a test report with a variant of uncertain significance, you can go back every few years and check with your provider and say, hey, would somebody take a look at this variant again and see if there's any more evidence that would help us to move it up or down in that classification scale and get more certainty. I wanted to include some of the other terminology that might get used on genetic test reports or that people might talk about because we get a lot of questions about these things. So as I mentioned, the variants we were looking at the other, at those example test reports are substitution or missense variants, where one thing is swapped for another, but the rest of the protein stays the same. And so it leads to an abnormal protein being made, but whether that's a problem or not depends on what is swapped and where it is in the protein and whether that protein can still do its normal function. Sometimes people will also talk about a nonsense variant, which essentially just means there's an early stop signal. So there's a variant in the DNA code that changes the code for one amino acid into the code for stop. And that means in most cases, as I mentioned, that no protein is made from that copy of the gene. Sometimes people will say, oh, there's a frame shift variant, and I'm not going to get into a lot of detail, but essentially that's a variant that changes something at one position in the gene, but also alters the way that the rest of the gene is read. So all the rest of the information gets shifted, and so it codes for different amino acids for the whole rest of the gene. And often that means that because of that shifted reading frame of the gene, grouping different DNA bases together than would usually be grouped together, you frequently end up with an early stop signal at some point downstream from that genetic variant. So here you can see in the terminology in the report, this is saying, well, this amino acid at this position is switched for this amino acid, but then it has this FS for frame shift and the little asterisk to indicate that there's an early stop 14 amino acids downstream from where the variant happens. So again, if there's that early stop at some point, it usually means that no protein is made from that copy. And it's essentially the same as a nonsense variant, or it's one of the kinds of variants that we call a null variant. The full gene deletion should hopefully be self-explanatory. If you have a full gene deletion, it's just a loss of the whole sequence of the gene. And so there is no C dot or P dot description because there's no coding DNA to have a variant at one particular location. The last line on this table is the splice variant, which this is one of the most difficult types of variants to know what to do with. The reason for that is that splicing is just sort of part of the processing when DNA is transcribed to make RNA. And if that splicing doesn't happen, if the RNA isn't kind of stitched together in the right order, and that RNA is abnormal, then of course that would lead to an abnormal protein being made. But sometimes the splice variant leads that RNA to be stitched together in such a way that it's very unstable and it gets degraded by the cell and no protein is being made. And so you can't always tell by looking at the splice variant what the outcome is going to be. So that's the very simple high-level explanation of what happens. But a splice variant means that something doesn't get put together well, and we don't really know necessarily what the outcome is going to be unless you do further testing. There definitely are some labs that are able to do RNA sequencing, where they look at that messenger RNA to see how it got stitched together and figure out what the outcome is. But that's not part of typical genetic testing for most laboratories. They'll just say this is a splice variant. We think it's likely pathogenic because we think something bad is going to happen to that RNA, but we don't know exactly what. Okay. So what can you do with the information from this genetic test report once you know that you have a variant in a particular gene and that variant is classified as pathogenic or likely pathogenic, so you've got a diagnosis of a condition? So sometimes that specific variant is useful in figuring out prognosis. If that variant has been seen before in other people or other families, you might be able to get information about what happened with them. If this type of variant is associated with typically milder or more severe disease for a particular condition, that can be useful information. So for example, in some conditions, a null variant leads to a milder presentation, as in vascular EDS. In other conditions, such as Marfan syndrome, a null variant does not lead to milder presentation. In some cases, people have more complications with a null variant than they do with a missense. So you can figure out from what's found on your genetic test result if there's anything that's known about that. And as I said, this will tell you what kinds of complications you might want to anticipate. It will help your providers figure out what screening is appropriate and at what age that screening should be done. People also may use genetic test results for family planning. So there is technology that exists to do pre-implantation genetic testing for monogenic disorders. So PGTM is the abbreviation you may see, and a monogenic disorder just means a condition that's caused by a variant in one gene. This involves doing in vitro fertilization, so providing sperm and eggs to a laboratory so they can create embryos and then test those embryos for the known genetic variant in the family. And then people have the option to transfer an unaffected embryo to try and establish a pregnancy. This is very expensive. It's not an easy process, but it does exist. Sometimes people will use genetic test information to do prenatal diagnosis for a pregnancy that's already established. And there are a couple of times when you can easily do that kind of prenatal sampling during the pregnancy. And then in addition, the genetic test result can sometimes be useful to think about timing of pregnancy versus timing of surgery, or what kinds of surveillance should be done during pregnancy if the pregnant person is affected with one of these conditions. And the other very common reason that people use genetic test results is that they want to benefit their family. They want to do what's called cascade testing and let all of their relatives test for the known condition in the family to see if they're at risk for some of the complications. This is usually most efficient if you start with the closest relatives to the person who's first been diagnosed. But if they don't want to be tested, other people in the family can still be tested, no problem, if there's a known genetic variant. As long as their provider knows exactly what genetic variant to look for, they can order the appropriate test and get a yes or no answer about whether the other relatives have that same genetic variant or not. Okay. And my last advice about genetic testing is that if you're going to do it, if you haven't already, get help from somebody who is familiar with genetic testing, whether that's a geneticist or a genetic counselor or some other kind of specialist who is comfortable and has ordered genetic testing before. The reason this is important is that it can sometimes be tricky to select the right test, and it can sometimes be difficult to navigate the billing and insurance aspect of it. So we don't want you to get a bill for $2,000 that you weren't expecting because your provider didn't know how to make sure that your test would be covered by your insurance. And then when you work with a provider who's familiar with genetic testing, that will ensure that they choose a lab that offers clinical genetic testing. So sometimes we get questions from folks who've done like a direct-to-consumer ancestry test that also offers some health information. And that's not the same thing as being tested for the conditions that we're talking about today. Those tests are not set up to identify people with Marfan syndrome. And so a lot of variants can be missed by the technology that's used in those tests. So that's my best advice. And my final word, I guess I will say, is that genetics is not destiny. So you can read your genetic test result, you can look at the variant, you can see what's happened to other people in your family or other families who have that same genetic test result. But that doesn't actually give us a crystal ball to know what will happen with you. So everybody is different, things are variable. There's so much that we don't know about why people have complications or don't have complications in specific genetic conditions. So I think what we try to do is offer people hope that we get the information we can, we do our best job to keep them safe and healthy. But it doesn't necessarily mean that something bad is going to happen or that you'll have the same experience as other people who have the same genetic test result. And with that, I want to make sure I leave some time for questions. Thanks to everyone that I work with and to the organizers of this event. And my email is here. Please do feel free to contact me with questions.
Thank you so much for that presentation. I love how you broke it all down. It sounds very complicated, but you do a very good job with trying to explain it in terms that we can all understand. So let's see, let's go to the questions here. I'm going to ask a couple of, let's see, there is a question here related to eyes, and I just want to tell that person that we're going to hold off on that. We don't have a speaker on that at the moment. So here's a question for you, Lauren. It's enough to know, is it enough to know that the gene affected is FBN1, or do I need to know which is the amino acid affected?
That's a great question. So if you know that the gene affected is FBN1 and you know that there's a pathogenic or likely pathogenic variant, you can get very good care. If you don't know the specific genetic variant, there are good guidelines for people with Marfan syndrome, and your provider can order all of the right kinds of surveillance and things for you. Some people like to have that additional information to see if there's anything more that we can learn. But the really important piece is knowing which gene and knowing that the variant that was found was pathogenic or likely pathogenic. So we definitely, want to confirm that that diagnosis is real.
Okay, great, thank you. If a patient has a variant of unspecified significance in several different connective tissue disorder genes, for example, COL3A1, FBN2, COL12A1, I don't know that one, can these together form a pathogenic condition?
That is a great question. And the simple answer is no. These are all uncertain variants. They probably mostly don't mean anything. We don't usually see people having sort of a combined connective tissue condition with the information that we know now that's caused by a bunch of variants in different genes. We get test results back all the time that have 8 variants of uncertain significance. And we don't worry about that person any more than we worry about the person who has a negative genetic test. Until you have a pathogenic or a likely pathogenic variant, we really are just looking at your clinical features and taking care of you based on that.
But how about this? And that's a question from somebody who's here. How common is it if you have a variant of unspecified significance, but you have clinical criteria for Marfan, like from the GED criteria, which is the latest?
Yes, that is a great question. So you can still have that clinical diagnosis of Marfan syndrome. You can be taken care of, the same way that we take care of anybody with Marfan syndrome. Having that positive genetic test is not the only way that we decide how to care for somebody. So if you have a variant of uncertain significance and it really matches your clinical features and it's a very specific picture, that's a variant we're going to be much more suspicious of. And so you'd really want to work with a geneticist or somebody who has deep expertise in genetics to figure out what should be done about that variant, whether you test other people in the family for it, even though it's technically classified as uncertain significance. We don't usually do that, but because Peter Byers has so much experience with this gene, in our center, we're able to sometimes say, this lab hasn't caught up yet. This variant probably really is the answer. And then we can use that information.
But I mean, if somebody, I guess people are really concerned about having a specific diagnosis, black and white, but you still, if they have certain features, clinically, you still need to be followed,
yes,
perhaps less or more, depending on if you know the genetic cause, but in any event, followed. Right?
Yes. Yeah. If you have certain features, you need to be followed for that. I think where people get caught up and get in trouble is when you have clinical features that are very common and non-specific. So like people who have scoliosis will come to see us and say, do I have Marfan syndrome? And we'll say, well, if all you have is scoliosis, that's super common. And most people who have scoliosis don't have Marfan syndrome. So that doesn't let us give you a clinical diagnosis.
Right.
Whereas if you have lens dislocation and an aortic aneurysm, that is much more specific for Marfan syndrome. We'd be much more likely to give you a clinical diagnosis and follow you based on the Marfan guidelines.
Exactly. Thank you for clarifying that. Testing embryos for a variant, is that generally covered by medical insurance or not?
No, unfortunately, most insurance does not cover testing for a genetic variant. I know of a few rare cases where people have figured out how to get insurance to cover it, like they work for Google and they had really good insurance coverage. But there also are some organizations that help provide funding for people with genetic conditions or for people who have infertility and need IVF and can't get it because of financial reasons. So there are some resources.
Okay, thank you. This is kind of specific, but does C101010T greater than G mean that a G replaced a T or a T replaced a G?
Yes. So the base that comes first in the description where it says we say T to G, that means that T is the usual and it's changed to a G. So the second one is the one that's been substituted in that's not usually there.
Okay. Wow, you made that sound so simple. Can you expand on the difference between echo screening versus getting genetic testing for at-risk relatives?
Yes. So if there's a known pathogenic or likely pathogenic variant, so very clear genetic test result, then at-risk relatives can get tested to see if they need echo screening at all. If somebody has a clinical diagnosis of Marfan syndrome, for example, or they have a variant of uncertain significance, then we wouldn't be so confident that we could rule out risk for people just with a genetic test. Then we would want them to get an echo to see if they have an aortic enlargement.
Okay, thank you. Last one, what does the position number tell us about the prognosis?
It totally depends on the gene and what is going on at that position. So some positions in a gene are very important because maybe they are a part of the gene that interacts with something else and lets the protein do its job. So you can't tell whether it's sort of at the beginning of the gene or the end of the gene or the middle of the gene, what the impact is going to be. It really depends on what happens at that position in the gene, and that varies.
Great. Thank you for all for your time and for the clarity on so much of this, which is just so complicated for all of us, really. And I've been around this for a long time, and you listen and you're like, oh, it makes sense, but it's really hard stuff. And when you have your specific situation, it's great to have somebody like you here to explain that to us. So thank you so much for your time. I know you'll be back later. You have another brief piece you're going to be presenting this afternoon.
Yes.
So
yep, I will.
Thank you so much.